Okay, welcome back. Again, thank you to our sponsors. They're all out there, and we have fantastic food here. And it's great to be back at the Lawn Club. I must say, I like the location in town, so we'll try to keep our meeting here in years to come. So it's really my honor. It's my true honor and pleasure to introduce the keynote speaker. This has been our policy, I guess, since I've been doing this with Renee, almost 15 years, to have a keynote speaker every year, right after lunch, something a little bit different, something new and exciting. And I think you would all agree that how to treat brain metastases, as we're getting much better, we've heard about all these tumor types where we're making great effects on systemic disease. But the disease in the brain, how do you treat it? Isolated metastases, can you use stereotactic treatment? So we thought it would be really nice today to have a talk on that, and we asked Dr. Veronica Chiang. Now, she has a number of titles. She's the Assistant Dean for Admissions. Those are the additional titles. The main titles are on the first slide. Hold on. So she's got a lot of titles. She's the Director of Stereotactic Radiosurgery. She's a Director of the Gamma Knife Center, the Director of the Stereotactic Radiosurgery Fellowship, the Associate Vice Chair for Academic Affairs for Neurosurgery. She's a Professor of Neurosurgery, and the Assistant Dean for Admissions, in case anyone wants to go do another medical school training. Now, I'm really excited that we have her here today. She's also a close collaborator of ours on our lung cancer spore. So we are really happy to have you here, Veronica, to talk to us about MRi-Guided laser ablation for management of brain metastases. Now, if you'd come up, please. A few years back, we started giving out a plaque for this because it's very special. Although Eric gave the talk last year and we didn't have a plaque. So is Eric here yet? So when he comes, don't tell him we gave a plaque today. But we have this wonderful plaque, and it says, Yale's Review of Advances in Oncology, highlights from the ASCO annual meeting, September 26th, and this should look very nice in your office. So we'll get a picture here. And now I'm not going to take away from your time. Thank you so much for taking time from your schedule to be here today.
All right. So thank you, Roy, for that really nice introduction. I wish you would stop telling people about my admissions work. But anyway, it's a real honor to be invited to give this keynote speech. Now that everyone's had lunch, I feel like we've upped the ante a little, and I have to keep you awake and try not to give you indigestion at the same time. But in all seriousness, this collaboration with medical oncology here at Yale has been fantastic for me, and I'm very grateful for your interest in what we do in neurosurgery. So when I asked Roy what to talk about today, he said, "Why don't you talk about cool tech?" And I said, okay, I have a lot of cool tech. So what we are going to do is to talk about MRi-Guided laser ablation for the management of brain metastases, and this is shortened to LIT, which stands for laser interstitial thermal therapy. And so just to give you, and so before I start, okay, and so before I start, here are my disclosures. I don't have any learning objectives other than just to give you an idea of what it is that we do. All right, so laser interstitial thermal therapy is the same as laser thermocoagulation, is the same as laser ablation. And so burning holes deep inside the head is something that we've been doing for a very long time. We've been doing it for movement disorders and psychosurgery and chronic pain and even for tumors. But for tumors, we've not really been all that successful. We've tried radiofrequency, microwave, most recently focused ultrasound. But the biggest challenge has been control of lesional size. And so laser is really kind of the latest way of delivering heat to the brain. And how does it actually work? Well, so if you look at the bottom here of the picture, so laser light, you put the laser in the brain, you turn the light on, and that light is then within a set wavelength that you can see up there. is either absorbed, scattered, or reflected from the tissues. And it's the absorbed light that actually turns into heat. And so what's really great about brain metastases is that different tissues have different reflection to absorption to scatter ratios. And so tumors absorb light very well. Hemoglobin and pigment absorbs light very well, but edema actually reflects the light and doesn't really absorb it. And so for the first time, we have a tool where the boundaries of the lesion seem to naturally take to this therapy. In addition to that, what's allowed us to really advance this area is a technique called MR thermometry, which was first described by Veronica up at the Mass General back in the 80s. And basically, using continuous gradient echo imaging, we can actually map each voxel on your MR scan, and we can watch for changes in those voxels that can be translated into temperature. And so pay attention now, because there's a test after this for this equation. But basically what we do then is take that information, put it into a complicated computer, and then it spits out a real-time visual map of the areas of tissue injury. So just to walk you through the process in the operating room, so down at the bottom left, we stereotactically drill a access hole through the skull. We biopsy the lesion, which is something that we can talk about later. We then, in the upper left, we place the laser. On the top, we wrap the patient up and we drive them into the MR machine. And then in the bottom right, we confirm that the laser is where we want it to be. And then, okay. And so then, what you can see here are axial images across the top and coronal and sagittal images across the bottom. The blue line is the lesion, the yellow line is the evolving heat and thermal injury to the tissues. And so obviously when the yellow line gets outside the blue line, then we are done with treatment. And this has become, over the last decade or so, a pretty popular treatment for those who have access to it. And so just to give you perspective, obviously craniotomy has been around for many decades now. Radiosurgery around for less than that. And so in the world of neurosurgery, this is still a very young and developing tool. But regardless of that, what it really is the first minimally invasive procedure that we do in neurosurgery. The incision is no more than 5 millimeters in length. We still do need to give steroids afterwards. But patients, for whatever reason, do really well, and most of them are able to go home post-op day 1. And so to the right is a summary of kind of the national experience with this, and you can see that very few of these patients spend ICU time anymore. The hospitalization is short, it's usually a day, and on discharge most people go home. And the complication rates of laser thermocoagulation have been distilled down to about the same as a biopsy. So as the tool becomes increasingly popular, we need to decide how we use it for brain metastases. And so as you all know, and I don't need to tell you this, brain metastases occur as part of a larger systemic disease. And so what's obvious for the neurosurgeon is that while local failure can shorten survival, success actually does not improve survival. That's dependent on you guys. And so the procedure itself must have complications or no complications to delay next steps in therapy. Laser ablation is still an invasive surgical procedure, so it comes with anesthesia risks, surgical risks, and procedure-related complications. And so what really is the role for this tool? So starting with untreated brain metastases, so brain metastases that you find on the scan that have not been otherwise radiated. So this is an area of significant debate within the neurosurgical community, but in my mind, the role is limited. It's because it's not a decompression tool, so we don't remove anything when we burn these lesions. And its current technology is limited to about, for some lesions, about 2.5 centimeters. And it's 2.5 centimeters, that's a lesion that we can easily treat with radiosurgery. And so what you can see in the images to the left is kind of, it's an imperfect picture of kind of what we think we're done with. And to the right is kind of the course after laser for an untreated brain metastasis. So the first MR shows the lesion. The second shows post-laser procedure, and so it looks very much like we have encompassed the lesion, but you can see at 3 and 4.5 months that the lesion starts to continue to grow. And so at 4.5 months, it's a lot more difficult to treat that lesion than it was prior to laser. And so other than in situations where we are going into biopsy anyway, for diagnosis, there's very little reason to be lasering an untreated brain metastasis. The biggest indication today, though, is for brain metastases failing radiosurgery. And so as you all know, radiosurgery has become first line, whole brain radiation therapy being taboo almost today. This graph just shows kind of that we are increasing the use of radiosurgery, not just first line, but second line, third line, et cetera, all across the country. And so radiosurgery is great, or used to be great, when patients only live 6 to 9 months. But as you're all hearing now, survival is, for some subpopulations, significantly longer than that. And so you can see, and so this is a volume over time graph, starting at radiosurgery at 0. And so if you live 6 to 9 months, then everything's great. The lesion shrinks, it responds, the edema goes away. But if you live longer than that, then there is a fair chance that your lesion, so up to 30% of lesions in about 50% of your patients, will have trouble with these lesions regrowing at some point. And so as we do more radiosurgery, there are more lesions regrowing. And the biggest issue is that we still don't have a good way to differentiate regrowing tumor from radiation necrosis. And so this is kind of an example of an MR perfusion scan showing kind of mixed changes, and it's very hard to tell whether there's tumor in here, whether this is not tumor, et cetera. And there's an increasing discussion that if radiation didn't work the first time for your lesion, why would you want to radiate it a second time round? So I wanted to share with you one of the cases that really drove me to start laser thermocoagulation. So back, this 31-year-old lady with triple positive breast cancer. So back in 2013, we still believed that whole brain radiation therapy plus radiosurgery improved survival. So this lady had, all the way to the left, 6 of these tiny little lesions treated with radiosurgery plus whole brain radiation therapy. About 8 or 9 months later, you can see in the next images over that something started to recur in that same area. And then by October of 2014, she had a significant lesion there again. So she went to a local neurosurgeon who said, well, she's got stage 4 breast cancer, and this is not really a great surgical target, so why don't you just go ahead and radiate that again, which we did. Unfortunately, 4 months later, you can see that the scan didn't get better. It got significantly worse. She was aphasic, hemiplegic at this time. And you can see by PET and MR spectroscopy, so that's how long ago this was, it all looks like it's tumor. So we go in there and we try and take it all out. And there was not one single cancer cell in this whole lesion. And she went on to die of surgical complications. And so not only would it be helpful to be able to work out what this is, but imagine if we had interfered in the middle slide, in the middle picture, right? And she may still be alive today. All right. So I'm going to try and encourage you all to consider surgery as a part of managing lesions that fail radiosurgery. And so the first advantage is tissue diagnosis, right? Many of the times we are guessing. Many of you call me and ask me what my guess is. And so this is a really rare example, but just to highlight really that sometimes we don't know what we're doing. So 75-year-old lady, KRAS mutant adenocarcinoma of the lung, had 35 other brain lesions treated with radiosurgery successfully, except for this one in the right temporal lobe. And so you can see here, got radiosurgery 3 times before she finally showed up at our institution. And we said, maybe that's not tumor. And she said, well, I don't want a craniotomy, which is, what we needed to do. And so instead, we're able to pop a little needle in, go down, get a biopsy, and this turned out to be a GBM, right? A glioblastoma, sorry. So that's rare, but it really highlights that sometimes it's important to get tissue. I think more importantly than that, getting tissue is also important as we advance through medical systemic therapy. And so this is work that you're all familiar with from Priscilla Brastianos up in Boston, showing that 53% of cases could possibly have actionable alterations in the brain that were not detected in the primary tumor. And so trials like the Alliance trials that are opening up specifically for targeted therapies for new actionable mutations, I think are coming on board. And so we need to provide that data so that patients might be able to benefit from these trials. And lastly, craniotomy has been shown for a long time now in radiation necrosis to be helpful in survival. And so on the bottom left, you can see that where you go ahead and get all the tissue and it shows no cancer, that survival can be significantly better than if there's a tiny little bit of cancer left. All right, and so from the laser side, we have now done several large studies. They've all been prospective, although not randomized in any way, collecting prospective data on patients getting laser for this indication. And so what you can see here is that for radiation necrosis, if you look at the right-hand box, that for radiation necrosis, we actually can get really good control. For tumor, not so much, and some of that is technique-driven, but we can talk about that. So I just wanted to give you a couple of examples of patients who have done well over the years. It's a 42-year-old lady with metastatic melanoma. She had this insular lesion in the left side that got radiosurgery. You can see it shrank at 3 months, looked really good, and at 12 months it came back with a vengeance. Was hot on PET. And the left insula is not a great area for neurosurgeons to be operating in, a lot of stroke complications afterwards and things like that. And so you can see that, so all the way to the left is prior to laser. The next one over is 2 weeks post-laser. And so just so you understand, as you interpret the images following laser, the lesion is always going to be larger than the original lesion because we have to ablate all the way around to be effective, all right? But what's interesting about it is if you look at the flare images underneath the contrast enhanced image, that by 2 weeks already the edema has started to get better, even though the lesion's bigger. And then she actually went on to 5 years of control of this lesion. Similarly, non-small cell lung cancer on chemotherapy, got radiosurgery to this left temporal lesion. This is also not a good place for us to be operating because speech cortex lies immediately overlying this. And so you can see that in May of 2021, the lesion has started to regrow. We watched it for a little bit because we weren't sure what it was. June of 2021, it got significantly bigger. And so what laser allows us is an alternative access path to this lesion. So instead of coming through the temporal lobe and knocking out her language, we're able to come occipitally. This is a more traditional approach for epilepsy. And then following the laser ablation, some fractionated radiation to get control. And so she went on to many years also of good control. For radiation necrosis, 48-year-old lady with metastatic melanoma on Ipi-Nivo. Her course was very complicated. She had horrible autoimmune pancreatitis. She had brittle diabetes. She was losing her vision. And I said, well, how about we just use some Avastin? And our medical oncologist was like, she's already on like a whole bunch of stuff. Why would you want to give her additional Avastin? So we went ahead and lasered this. And so you can see that by the time that we lasered the lesion in June of 2024, the lesion was very big. The edema was very large. There was midline shift already. And what was really amazing with this was that, so all the way to the left, pre-laser, 621, post-laser. And so the lesion itself, again, is bigger. But you can see that in 2 weeks, the edema had gotten significantly better again. All right. And so last example, this is non-small cell lung cancer, 23 lesions in the brain treated with radiosurgery. This right basal ganglia lesion is associated with a lot of edema. She was very symptomatic from that. Again, not a great place for an open craniotomy. And so we lasered, and you can see again how quickly the edema got better. And so I think one of the biggest things with the laser procedure is this time to steroid independence. And And so this is a study by Peter Fetchy down in Duke, showing that the dark gray areas is how long it takes for edema to get better with the laser, and then the light gray, how long it takes with medical therapy. All right. And so translating that forward then into patients who are getting immunotherapy, where you really don't want to be using steroids at all if possible, we've had a lot of success with taking care of these people. And so again, you can see a lesion all the way to the left, post-radio surgery, in the middle after laser. Lesion again, not significantly different in size, edema resolving quickly, even on immunotherapy. And so the Lantern Registry is our prospective registry across 14 institutions where we've been collecting data. And so what you can see is that the median time to steroid cessation across all of our centers is actually 13 days. That's 2 weeks. And I think that's a lot less than we struggle with when we put patients on steroids and watch with serial imaging. So how does laser compare to the other technologies that we have? Well, certainly for craniotomy, what you can see here is that all the way to the left is a comparison of the technologies, and all the way to the right, comparison by lesion pathology. And so for lesions less than 3 centimeters in size, and this is critical in trying to choose these patients, it's really less about the tool we use and more about the pathology that drives outcome. Some of the additional advantages of laser: we can treat multiple lesions. We can sometimes come through additional areas, so even if they've had surgery or trouble with healing, we can come through novel regions to avoid prior wounds. And then for radiation necrosis, and so there's not a lot of data comparing laser to Avastin, but there are 2 papers, one by ourselves and one by a group up in Boston now, that show, interestingly enough, and so again, a volume over time curve on the right. The blue line is the laser line. So again, we talk about the lesion getting bigger before it gets smaller, but then a slow but persistent decrease in size to below its original. The black line is the Avastin line. And so we see this, right, where it gets us out of trouble really quickly, but a significant number then will start to regrow subsequently as a rebound phenomenon. And so we encourage you to consider that if you think that your patient is surgically eligible, and we realize that this is not everybody in your population, that you might want to consider laser for a longer term result. All right. There's still a lot that we don't understand about the laser. This is that same lady that had the pancreatitis and the uveitis and wasn't doing really well, and that front lesion did great. So then we were like, well, let's just, because when the back lesion grew, we were like, let's just do that too. But for whatever reason, that didn't turn out as well, and we had to do a craniotomy for that. And so there is significant variability across the results from the laser. It's not a guarantee. We still don't completely understand what factors drive this, but we're hoping to look into that. All right, and so with that variability, how might we make this more successful? And so one of the things that we learned from our very first laser study was that there's a difference between complete ablation of the lesion and incomplete ablation. And so if you look both for radiation necrosis and tumor recurrence, if you 100% ablate the lesion, you will take care of things and it will go away. If, however, you incompletely ablate it, then that's when you get partial response or, in fact, disease progression. And so I have, in our institution, advocated very much for being aggressive with using the laser where it's reasonable. So this is a lady who had lung cancer. She had these 2 lesions up in the upper left that you can see, got radiosurgery, and then one of them started to regrow with edema around it. Now, this patient is not symptomatic. The lesion is small, and for all intensive purposes, we could have watched this. But our experience has been that if we leave these alone, particularly if you're on immunotherapy, that they can grow into something significantly worse. And so we, while she was still healthy and well, we took her to the operating room, we lasered it. She got 1 single dose of steroid. She was home post-op day number 1, and she went on to 12 months of uninterrupted immunotherapy. And so this is data that's kind of fresh off the press. It's not published yet, but as part of our Lantern study, What we've been able to demonstrate again, so bottom left, is that for radiation necrosis, we do well with laser. With recurrent disease, it's still not as great. But if you've got recurrent tumor, then if you can get to the lesion before it's 2.5 centimeters in diameter, then we will likely do well with laser. And if we can 100% ablate the lesion, then we can improve progression-free survival. All right. And so, in summary then, I think there is an unclear role for laser in untreated brain metastases, but laser is a good option for treatment of lesions regrowing after radiosurgery. And patients prefer laser to craniotomy, hands down. The advantages of LIT, it facilitates obtaining tissue without an entire redo craniotomy. For tumor recurrence, local control is equivalent to craniotomy for lesions less than 3 centimeters in diameter. Again, for tumor recurrence, it's associated with better survival if treated when small and with 100% ablation. With radiation necrosis, we can avoid a break in immunotherapy by managing your edema, and we think that for radiation necrosis that the laser effect lasts longer than bevacizumab. And so I think for the first time, the laser ablation technology fills a unique space where we can treat these recurring lesions early before they cause trouble, and when the risk-benefit ratio does not favor craniotomy. So these procedures are great for patients. They love these. They go home the next day. It's not very much pain. But what it really does, unfortunately for the surgeon, is it requires an entire village to do these procedures. And so I'd like to thank our team who have done this for me over the last decade, done this with me over the last decade. All right, thank you for your attention, and I'll take any questions.
Thanks for that wonderful, wonderful keynote. We have time for a question. Yes, please.
2 questions. At the beginning of your talk, you talked about 2.5 millimeter lesion, and then at the end you were talking about less than 3 centimeters. So did you mean at the beginning there was 2.5 centimeters?
Yes, my mistake.
Oh,
2.5
okay.
centimeters.
Thank you.
Yes.
Another question. I don't understand how you physically are getting the probe to the lesion. Are you making a little hole in
Yes.
the skull?
Yep. So
And is the patient in or surrounded by MRI machine while this is going on, or what?
So we have an intraoperative MRI, but for many of the procedures, so stereotactically it's a standard like a stereotactic biopsy. The laser is just inserted into the lesion through the skull hole, and then they are transported to the MR, wherever that is, for the laser ablation portion.
Patient is moved under
Yes.
anesthesia
Yes.
to different...
They can be awake as well. So yes, they just need to be moved into an MRI. Correct.
with the surgeon walking with the patient?
Yes, if necessary. Yeah, we have an intraoperative MRI, so we just stay in the operating room.
Thank
But
you.
yes, many centers have it outpatient.
Time for another question. How do we make referrals to you? There are people here from all over Connecticut. What's the best way?
So I think most of you know me already, but Veronica.Chiang at Yale.edu is an excellent way. Or please feel free to call Yale Neurosurgery, and my nurse is Patty. She's been doing this with me for a very long time.
Okay, so cutting-edge technologies with expert administration. Thank you so much, and really appreciate you being here today.